Hello medicos, so hope you are doing well. So today I will be talking about a common procedure that is thoracocentesis. Now you everybody know what is thoracocentesis and the most common procedure in our hospital. And you might be knowing pleural effusion, that is excess amount of fluid around the lung in pleural cavity. Now talking about the thoracocentesis, first we will talk about the procedure, what is it, and all the details regarding thoracocentesis. Now coming to the next introduction, first let me show you a video. You can see this how this blood fluids are being taken out. Now next going to the introduction. Now let me tell about what is thoracocentesis. As you know, it's a removal of fluid from the pleural space using a needle. And the thoracocentesis is done for two purposes. There is diagnostic and therapeutic. For diagnosis, you can refer for a removal of small volume of pleural fluid for analysis, and for therapeutic, removal of large volume of pleural fluid for seeking relief for the patient. Now it has some contradictions, like you have to be cautious for the patient who is having coagulopathy, onco-operative patients, skin diseases like herpes zoster or cellulitis at the site of aspiration, mild diffusion where localized and difficult uncontrolled coughing. Don't worry, these all notes will be provided to you in the description of the link, and also in our group, that is AIM4PG.com, in Telegram groups, in notes group we will provide these notes. So no need to take it down. All the things will get, all the materials will get. Now coming to pre-procedure investigation, we usually do complete hemogram and BT, CT, PT, INR, APTT if the procedure happen. BT is bleeding time, CT is protein time, and PT INR you know. And viral markers like HIV, HBs, IgE, HCV. We take informed consent from the patient, and what are the things we need to be arranged for thoracocentesis. This is lignocaine 1%, syringe of 5 ml, 10 ml, 20 ml, 50 ml, depending on how much you want to take out. Needle, that is 26G or 22G. If 22G is taken, 2 needles we need. Now we need also 3-way adapter, and 3-way adapter with 10 cm extension if pleural catheter is being placed. Gauges, sterile drapes, betadine and stellium to prevent from infection. INICET if therapeutic aspiration is planned. Empty bottle for aspiration, and sterile container to send the sample for investigation in diagnostic purposes. Bedside table for patient to lean down so that the more visibility and uh, more quickly you can take out the fluid and very vividly. Now patient positioning, how you have to make the patient positioning. The images you can see, and also images I will put it down. Patient be in room, in minor procedure room. Patient preferably in sitting and leaning forward position. If not able to sit in supine recumbent position, and mark the site for expression in that position. You can see the position, right? The black and white image is shown. Now the procedure, first confirm the site for aspiration but by percussion in mid scapular line. For more details about percussion and the physical examination, I will be making one another video. All details of the physical examination I will include in that. Now coming to thoracocentesis procedure, ideally one space lower than the upper border of dullness. Clean the area with betadine and then chlorhexidine and put sterile drapes to prevent from infection. Infiltrate skin with lignocaine and go through the upper border of the rib through the pleural space. Give local anesthetics as the needle moves towards pleural cavity. Give negative pressure whenever the needle moves toward the pleural cavity to prevent accidental puncture of lungs. Now once the pleural space is reached, remove the needle, reinsert another syringe with 3-way attached system into the space and aspirate the fluid. If catheter has to be inserted, insert the needle into the space. Once space is reached, insert guide wire through it and remove needle. Insert the catheter by Seldinger technique and fix the skin via sutures. A 3-way with 10 cm extension can be attached to a catheter, which is then connected to underwater seal with an IV set. Why underwater seal? The bubbles will be prevented. Now do not drain more than 1 liter per day due to risk of re-expansion of pleural edema. If develops cough even before, close the drain or stop aspiration. Now what can be the complications? Complication will be like pneumothorax, re-expansion of the pulmonary edema, bleeding, accidental puncture of liver and spleen. Now another complication is like vasovagal syncope. Now post-procedure monitoring. How will you monitor after the thoracocentesis is done? Chest X-ray, not routinely indicated but you can done to check the position of the tube. Now to rule out pneumothorax, so the chest X-ray done, and after 1 day of SS, resolution of the effusion or reaccumulation of the fluid. Now analgesic can be given like paracetamol 500 mg if required, and monitoring vital after 1 hour. So this is it for the thoracocentesis procedure. Now this image containing everything in one page I will be posting in our Instagram, that is AIM4PG med, and also I will be giving group in AIM4PG Telegram group and in website also. So more procedures and videos and more spotters will be taking out. These are the groups you can follow in aim4pg.com, the study group and everywhere. So let's get to the next topic. Thank you for patient listening.